Hello and welcome again to another edition of the Osteopathic Lyceum podcast. I'm going to speak to an article that is currently in press in the International Journal of Osteopathic Medicine, and it's referring to a previous article, both of which the abstracts are only available. So I'll give the title of the first one, I'll go to the previous one, and then I'll come on back. So the one that I want to really, I'm commenting on both, so I think it's more fair to say that I'm commenting on both. The first one, or the most recent one, as of November 11th, 2025, is The Metaverse as a Pedagogical Clinic, Re-envisioning Human Presence, Empathy, and Touch in Digital Care Training. So that's what inspired me initially to consider some of these concepts, especially with respect to things that I was made aware of or I learned about in my health science education training. So I'm going to go to forget that. I'm going to read this abstract and then I'll go to the other paper. So the abstract here, the recent phenomenological study by Eckott et al. 2024, entitled Lessons Learned from the Digital Transformation of Physiotherapy Education, provides timely insight into how the rapid shift to online learning has reconfigured professional formation in physiotherapy. To pull out of reading for a moment, I think it may be, I'm not sure when they say professional formation, if they mean formation of a professional or professional identity formation. In health science education literature or health professions education literature, you'll see professional identity formation. So I'm not 100% sure there. I would need to see the full text, which I don't have access to, which is admitted and likely okay for what this is going to inspire me to say. To read again, the author's identification of disembodiment with anatomy captures a fundamental pedagogical dilemma. How can health professions education preserve embodied knowledge, the essence of clinical practice within digital learning environments? Okay, so that sets the stage. What I'm going to do is go to the paper, or at least the abstract of the paper, that inspired this one. Give me just a moment to pull it up properly. So the title again of the one that was cited in the previous one, Lessons Learned from the Digital Transformation of Physiotherapy Education, a Phenomenological Study. So while obviously it is about physiotherapy, not osteopathy, both have requirements of basic science knowledge, both have requirements for hands-on skills. So in that light, in the abstract sense, they are the same enough that there's likely appropriate crossover for insight to be gained. The abstract. Do I need to do that? No, I don't need to do that part. I don't need to do the object. Okay, I'll read the objective. COVID-19 pandemic changed education globally with a rapid reduction of in-person learning and increase in e-learning. This was challenging for students with themes of poor motivation, reduced engagement, and difficulty translating knowledge into practical skills. Although COVID-19 restrictions have been removed in the UK, increased e-learning is likely to be permanently integrated in healthcare programs by most UK universities. Therefore, programs need to reevaluate their e-learning to learn lessons for the future. The study aimed to understand physiotherapy students' experiences of e-learning and what, if any, specific topics were more challenging and why they felt this was the case, to identify how e-learning can be developed to meet their needs. The first thing, when you're asking people how they feel about a process, without relating that to some form of outcome measure, you're often going to be in a place with the results where maybe phenomena don't line up the way you would want them to. It matters if people enjoy things because it predicts that they will engage with them. But it doesn't predict that it will help them perform. So you can like things that are harmful to you is a really simple construct. So, or like things that are not helpful. To read again the methods, a descriptive phenomenological methodology and purpose of sampling of physiotherapy students at UK University was used. Two semi-structured focus groups were conducted. Data was analyzed using reflective thematic analysis. When you see reflective thematic analysis, one of the things that you're going to have to consider the moment you see reflective is that people are including themselves, their preferences, acknowledging that there are biases they wouldn't be able to identify, but they're including themselves as interpreters that has a uniqueness. It is acknowledged when you hear the term reflective. Maybe not reflective. Reflexive is more accurate. But the reflective thematic analysis should acknowledge that the people doing the reflecting or the researchers are going to impact the results generation in a particular way, right? So that is somewhat unique. The ability to reproduce something of this nature is hard because it acknowledges the impact of the individuals, right? So to read results, 4 themes were constructed which were connected but disconnected: collaborative disengagement, practicality for professional identity, and disembodiment with anatomy. Okay, so the one that I was looking at previously that this kind of sparked my desire to talk about some of this stuff, specifically the final one, the disembodiment with anatomy. To read again, conclusions for vocational healthcare courses with substantial practical skill development required to meet regulatory standards. The balance of online and in-person learning will continue to be a challenge. The changes to education delivery, which occurred because of the COVID-19 pandemic, have provided educators with an opportunity to reflect on the challenges facing both students and the profession itself in this increasingly online world. Recommendations from this study include integrating online communication skills within the curriculum, prioritizing digital skills, and embracing emerging immersive technologies to enhance anatomy learning. Okay, so the quickest thing for me to do first with respect to immersive anatomy learning technologies, the work out of McMaster headed by Dr. Bruce Weinman and Danielle Brewer-Deluce. I'm going to admit that I'm probably not properly pronouncing Dr. Brewer's Deluce's last name. Danielle, fantastic researchers. One of the things that they were looking at specifically is impact on learning outcomes for anatomy with varying technologies, including immersive technologies such as VR goggles. It doesn't really do any better than a 3D plastic model for anatomy test outcomes. So the drawback for immersive technologies, it's expensive. It doesn't outperform previous methods. And as a result of that, you also often have to continuously update both hardware and software. So it costs more, it has to be renewed more, whereas a plastic model that can be rotated by somebody else will likely outperform the immersive technology. The assumption embedded in utilizing technology in education is that it is going to perform better. When tested, it often doesn't, or it doesn't necessarily. There are things with respect to simulation and fidelity of simulation where high fidelity simulation does not predict appropriate levels of performance. What it does seem to predict, there's one that Dr. Jeffrey Norman speaks about, I think it's Harvey. So it's technically a high fidelity medical simulator. So it's a body that has different heart sounds and different different pathologies that can be set by examiners, different emergencies that can be run through this fairly lifelike simulator. The problem is that it has a limited amount of, say, heart sounds, and a $5 CD with a much wider range of heart sounds actually outperforms Harvey with respect to the ability to identify accurately heart sounds in a variety of settings. So Harvey is high fidelity, but low transfer, whereas something less expensive, much lower fidelity, much higher transfer. So you've got to be really careful with these things with respect to performance outcomes and expectations. Technology doesn't necessarily make things better, and it is not an inevitability depending on the skill set. So a couple concepts I want to bounce around with respect to online learning and hands-on skills, okay? You can deliver information about hands-on skills in a variety of formats, be it in person and synchronously, or not in person and asynchronously, right? So synchronous is at the same time, asynchronous is at varying times. So you can deliver technical instruction as far as step-by-step things. The problem is that you will not have an easy time providing feedback. It's not impossible. You can provide asynchronous feedback if you have examples of what people are doing. So you could ask people to film themselves doing a procedure and provide feedback. And sometimes that feedback can be more accurate because it can be observed repeatedly. So there can be something there, but there is definitely something lost in the ability to synchronously identify the same phenomenon in somebody else. So whether you like the term patient or the term client, if a learner is working on somebody else's body or working with somebody else's body, depending on the terms you prefer or the terms you'll accept, the ability of an instructor to observe that, identify an observable phenomena, whether visual, auditory, or palpatory. And I pointed at my ear when I said visual, so I screwed that up. But anyways, auditory, so ear, visual for eye, or palpatory for some area of your body in contact with their body and feeling alterations or differences in pressure or resistance to movement. If an instructor is there at the same time, they can provide feedback that would help somebody tune in more accurately to the situation in a way that would be on target for desired goal. So hands-on skills can be taught asynchronously and online. They can be observed and provided feedback asynchronously and online. The problem is those areas or those times when the synchronous nature of delivery and feedback and observation would be more helpful. So none of these things are impossible, but they're challenging. So one of the things you want to figure out is the basic concept of an asynchronous resource or a synchronous resource. A synchronous resource is something that is delivered essentially once and at the same time or in person. So a synchronous resource could be an online video conference. So many people would say Zoom, but like an online video conference, whether it's Google Teams, I think, or Skype. I think Skype might have gone under. Don't remember for sure, but I heard something about that. But some kind of online video conference that is not recorded. Everybody gets the information once and at the same time, and there is no repeat of that information. An asynchronous resource would be the same thing that was recorded and provided to be accessed at any time. So a recorded delivery of information versus a not recorded delivery of information. You could have a synchronous in-person lecture that is a one-time thing. It is not delivered again. It is not delivered in the same way again, so you lose some stability of information. If you film that lecture and then make it available at any time online, it now be the same synchronous resource is an asynchronous resource. So asynchronous is at different times, synchronous is at the same time. Classically or historically, the sage on the stage, the lecturer, was the synchronous resource. The problem you run into is that while the information is delivered to everybody at the same time, not everybody is the same with respect to how they take that information in. As a result of that, you would generally have asynchronous resources. Those asynchronous resources could be assignments, right? So something that somebody had to go away from the learning space and do some work on their own time. So that becomes asynchronous. There were things like textbooks, right? Or some form of physical thing that had the same information or the required information that somebody could read on their own time or engage with on their own time. Now we do have internet-based technologies that allow for more multimodal or multisensory delivery of information, primarily auditory and visual. So we can have more forms of asynchronous resource. The thing about an asynchronous resource that is advantageous is that it is stable across time. You can film something once, and unless you have to update the information or change the information, it is always there, and students can have access to it at whatever point that they need or think they want. So you take care of a lot of engagement issues with an asynchronous resource. The people that want to work hard, they'll use it. They'll use those asynchronous resources in a variety of ways. An asynchronous resource can heavily reduce cost to any institution. And again, it doesn't have to be changed unless information needs to be added or something needs to be corrected. So your upfront cost can be a varying range, but it's in a relative sense a one-time cost. Your synchronous resources, the instructor observing performance, is where that instructor or that teacher or that lecturer or that tutor is able to observe where the learner is having a challenge, diagnose it, and provide feedback accurate to need, as opposed to just repetitive performance of the same thing. You actually end up with a much more dynamic environment if you offload almost all cognitive skills, so anatomy, physiology, history, theory, to the asynchronous environment. That can be textbooks, that can be videos, that can be assignments, whatever that is. It can look different ways. As long as everybody has access to it immediately and consistently, then you are taking care, you are allowing the responsible learner to take care of their own engagement, and you are ensuring that everybody has free access to the same information. They use it how they choose. So their outcomes reflect their engagement to some degree. With respect to the synchronous resource, if you are asking somebody to synchronously deliver information that can be offloaded to an asynchronous resource, you're going to run into a problem. Because there will be issues with fairness, there will be issues with sameness or stability of delivery of information. It will vary. So if you are having your synchronous time aimed at things that do better synchronous, such as the observation of physical performance and feedback, then you are likely doing better with respect to not only the delivery of those things, you have more time available for the delivery of those things. You have more feedback within that time frame. You have more correction within that time frame. You have more practice and more identification of error. So it is really about the fundamental concept of synchronous versus asynchronous, and what should be asynchronous, or what would be beneficial not only to an institution but to a learner that is asynchronous, and what would be most beneficial to everybody, again, institution and learner, with respect to the synchronous time. So the synchronous time should really be more about those hands-on things, those embodied things. Anatomy, depending on how you view it and which direction you like to argue, you can do in person, but if you wanted to do that, you'd probably be better doing something like a cadaver lab, or like study of a 3D plastic model. If you really wanted to do it, you might as well get the things that show the best performance, as opposed to expensive VR immersive technologies. They're likely not performing the way that people would want them at the moment. Maybe in the future it'll be better, but we've got challenges. One of the consistent findings with respect to VR and VR sickness is that people who have stronger prescriptions, vision correction prescriptions, are more likely to have motion sickness due to the VR environment. I think there's a little bit less signal there with what I have seen over time from the McMaster Anatomy Lab, but that's a consideration. Things like VR sickness, things like familiarization with the environment. So you're not likely to be in a position where all students will be able to do VR stuff. They probably won't be able to buy the headset. They probably won't be able to purchase the software. And if you want to do it, it's going to cost you a lot, because you're going to have to buy a lot of headsets, and you're going to have to buy the license, the multi-use license for the software. So it becomes cost challenging or cost prohibitive. So with respect to the delivery of any form of education, the most appropriate constructs are synchronous and asynchronous resources. If you can sort that out and figure out what you value to be synchronous versus asynchronous, not a lot of time thinking or ink spilling over the topic is required. You could definitely have a long arc of published work if you wanted to, but there is a little point. Anatomy, physiology, history, theory, nutrition, anything that can be tested in a written form, primarily with respect to reliability and validity of testing, multiple choice, despite what other people may think in a popular sense or in a common sense. With respect to the ability to actually measure things reliably and in a valid way, multiple choice tests are likely the best. Especially when developed properly. But anything that you can test in a multiple choice way, you can do asynchronously. You don't have to waste the time of the learner or the instructor in person on that stuff. It will cost less. It will likely be just as effective unless there is some portion of it, such as a cadaver lab, that should be synchronous and should be in person. With respect to hands-on manual therapeutics, the hands-on manual portion should be in person and synchronous. And that can be performed in a variety of ways, depending on your values, but that is probably the best way to use these environments and attempt to deal with the concept of online learning. Don't just assume that everything's going to be online. Don't just assume that AI is going to impact your profession. Artificial intelligence, or at least at the moment, large language models, are very unlikely to impact core performance in osteopathic manual therapy. And the rationale is people can score exceptionally well on cognitive tests or written tests and not be able to perform the actual practical thing. So artificial intelligence is not likely to impact the ability to assess, identify motion restriction of some form, interact with that in a way that doesn't make the person say ouch, that suits them, and then provably change it, at least on a gross motion level. Artificial intelligence isn't going to do that. And if you have axiological or value-based judgments, the value should be placed on the assessment of hands-on performance, and less weight is likely earned by the repetition of anatomy and physiology and nutrition and things of that nature, on account of most jurisdictions not having the opportunity for osteopathic practitioners to talk about nutrition, but also almost all hands-on therapeutics. People are going to forget their anatomy, and most instructors, most practitioners will happily admit, at least in my experience, that they don't remember their anatomy to the level at which they once learned it. So if you can assay the general population of a profession and they say, yeah, I don't use the anatomical knowledge in a highly specific way all the time, then you can recognize that weight can fall off of things like anatomy and physiology for a hands-on practitioner. That there is room for argument about that, and that is a totally fair thing to do, to say it needs to be at this level. Totally fine. As long as you can provide a valid argument for it, then there you go. You can do what you want. But with respect to education, those things that can be tested in a written form, asynchronous. Those things that should be tested in a synchronous form, or at least taught in a synchronous form with respect to feedback, do them in person. Right? So thank you for listening this far. Hopefully you learned something, and we'll talk again soon.